Hello, my name is Dr. Jeff Zobel. I'm a pediatric clinical pharmacist that has worked with cystic fibrosis patients for over 18 years. I'm a pediatric pharmacist in Arizona, along with my colleague, Dr. Kevin Epps, who's a infectious disease pharmacist in Florida. It's our pleasure to present the first webinar in our series for pharmacy care teams. And this is a Cystic Fibrosis 101 for care teams, which gives a general overview of cystic fibrosis, the medications involved, and clinical quandaries in the areas in this new era of highly effective modulators. My only disclosures is I am a clinical support liaison for EVW Nutritionals, which provides CF-specific vitamins and probiotics for cystic fibrosis patients across the world. So the objectives of this presentation are to describe the basic pathophysiology of cystic fibrosis and the organs affected. We're going to go through the current evidence and future directions regarding CF medications as well as antibiotic therapy in patients with cystic fibrosis. The antibiotics will be covered in the third webinar of this series. And then finally describing some of the medication access programs available for cystic fibrosis patients. The demographics currently released by the CF Foundation in the most recent register report that was published in the end of 2023 shows that there's over 105,000 cystic fibrosis patients worldwide. They're both pediatric and adult, with 40,000 of them living in the United States. Roughly 60% of all CF patients now are adults over the age of 18, which is incredible to see as someone who's been involved with CF for almost 20 years. This is something that is a very, very significant thing that has happened. But also the median age of survival of patients in the United States is age 56 from the most recent register report. Both parents have to be carriers of a cystic fibrosis gene, giving them a 1 in 4 chance of having a child with cystic fibrosis. There are 1,700 different disease-causing mutations that have been identified in the CF population, with the F508del a mutation being the most common, with almost 90% of patients having one copy of the F508del mutation. And then there's roughly 1,000 new cases diagnosed each year, and there were 750 diagnosed in the United States alone in 2022. So what is cystic fibrosis? It is a genetic progressive disease that affects organs of the body, the lungs, liver, and pancreas being the most common of these organs. The mutations in the CF gene, which is called the CF transmembrane conductance regulator, or CFTR, can lead to a non-functional CF protein channel. And I give the analogy of a lock and a key. If there's no channel at all, there will be no lock, no channel, or no lock that will be produced at all. And these are classes 1 and 2 of the mutations. The class 1 would be a G542X, would be an example of that. So anything that's an X mutation is a stop codon that is produced when the DNA and RNA do translation and transcription. So no CFTR is produced. If you're a class 2 mutation, example of that is the F508del mutation. And that is where there's no channel produced at all that gets to the cell membrane. If you're a class 3 through 6 mutation, this is where a channel is produced, but it doesn't work right. This would be an analogy of a rusted lock. The lock is there, it just doesn't work right. So examples of a class 3 mutation would be the G551D, and classes 4 through 6 are very rare mutations and usually not as severe. And those patients usually have some sort of pancreatic function, or some are diagnosed later in life if there was no newborn screen. But regardless, those have CFTR that is there, just doesn't work right. And so there's something that needs to be affected to help the channel to open or to work correctly. If a patient does not have cystic fibrosis, this is a kind of a flow diagram exactly what happens in this patient in those individuals. If you do not have CF, your DNA works correctly and your RNA, it gets translated correctly to have the pristine DNA and RNA, leading to the production of the CFTR channel, like the lock that you could buy at any hardware store. Then chloride ions are produced, leading to water attraction, which then leads to the thin mucus that you can see all throughout the organs of the body. If you have cystic fibrosis, any of these different mutations that we in the classes 1 through 6 mutations, the DNA and RNA are flawed, leading to something going on with the channel, either no channel being produced in a class 1 and 2 mutation, or the rusted lock in a class 3 through 5. So there's no or dysfunctional CFTR channels in these patients. Then causes chloride ions to either not be moved across the membrane of the cells, or if they are moved, it's in a less fashion, a lower amount. That can cause issues with the water attraction, either no water attraction or less water attraction, which then results in the thick mucus that you can find throughout the organs of the body, and analogous to a swamp. So the thick, sludgy mucus all throughout the lungs, liver, pancreas, and other organs of the body. These are the organs that are affected and the effects that you see. So you see it in the nasal passages, leading to sinus issues and nasal polyps. If they're in CFTR in the sweat glands of the body, leads to the salty sweat, and that's where people are diagnosed via sweat chloride tests being elevated. Patients can have acid reflux because the stomach is affected as well as the pancreas and intestines. Pancreatic insufficiency, so the pancreatic enzymes are not released from the pancreas, leading to vitamin deficiencies, fat malabsorption, and constipation. If a patient's liver is affected, it can lead to hepatobiliary disease, where the bile in the liver is not moving appropriately. You can have CF-related diabetes because the endocrine portion of the pancreas is affected, leading to patients developing diabetes, usually in the teenage years, and they don't start screening until after age of 10. And then the most common, or the most common cause of breeding mortality in our CF population is the mucus-clogged airways and lungs, leading to lung inflammation, frequent bacterial lung infections leading to hospitalizations, and can cause, eventually may lead to a lung transplantation in some individuals. Male infertility is also very common in the CF population because the vas deferens are blocked and can lead to male infertility. So as a pharmacist, we're going to go through the different areas of the organ systems where we have medications to help our the symptom-based management, especially of these areas. And this is divided into 3 organ systems of the body. The first being the gastrointestinal tract. And this was from the mouth all the way down, you have CFTR being affected. The first of these, and the most commonly supplemented and of medications used, is for pancreatic insufficiency, the pancreatic enzymes. And another acronym for this is PERT, pancreatic enzyme replacement therapy. If a patient is pancreatic insufficient, they can test for this via a test called the fecal elastase, which is an enzyme produced by the pancreas that gives stool its form. And when that number is checked, and if it's low, less than 200 micrograms per gram, plus having signs and symptoms of malabsorption, a patient is considered pancreatic insufficient. This is where the CF Foundation recommends that all CF patients who are pancreatic insufficient are started on pancreatic enzyme replacement therapy. Almost 90% of all CF patients are on some form of enzyme. All of these enzymes contain the 3 main pancreatic enzymes for digestion: lipase, protease, and amylase. Lipase dissolves fat, protease dissolves proteins, and amylase dissolves sugars. They're all standardized and dosed by the lipase units that are in each capsule. So when you see the different enzymes out there, and if they have the name plus whatever 1,000 units that they have, that is considered the lipase units, and that's how it's dosed and standardized. There are 5 pancreatic enzymes available in the U.S. market that are FDA approved. 3 of them, the first 3, are usually capsules within a capsule. By the package insert, they're not interchangeable, but some insurances do require that some specific enzymes are used. The 4th one, Viocase, is a tablet that can be crushed. Pertzy has capsules in a capsule, but also contains sodium bicarbonate in it to help. Its main purpose to help with patients who may have issues with malabsorption. After being on other standard enzymes, you can change them to Pertzy because of the sodium bicarbonate to aid with digestion. The one thing with Pertzy that is different, it can be, the Pertzy 4000s can be administered through a gastrointestinal tube for patients who have them, and can be administered that way. All of these are necessary for absorption of fats, proteins, carbohydrates, fat-soluble vitamins to decrease gastrointestinal symptoms and improve weight gain. There are copay assistance programs are available for patients in the United States who have commercial prescription insurance. If a patient has any government or state-funded insurance, such as Medicaid, Medicare, or TRICARE, they do not qualify for the copay assistance programs that are available. These programs are different. They all provide the assistance for patients with commercial insurance, but the differences highlighted is the Creon CF Care Forward program is available, and patients can get this. They can get a value-added program. All of these provide some sort of value-added benefit, such as CF-specific vitamins and nutritional supplements. For the Creon program, patients who are on TRICARE actually can qualify for the CF Care Forward program value-added benefit. They cannot get the copay assistance, but the value-added benefit they can receive. For the Zempep Live to Thrive, some things that are different from that is it can also provide patients with extra vitamin D through Carlson's vitamin D drops and the MVW Nutritionals MVW probiotic that can be given to those patients. Pertzy, the Pertzy Care and EPI Nutrition Program just changed their benefit just recently and to increase the amount of benefit that they do provide per prescription fill. And they also, patients need to submit proofs of dispense to the program in order to get their value-added benefit. The Pancrease Engage program is a little bit different. The copay assistance is roughly $100 a month, and then you get a debit card, like a nutritional savings card to go to an online store. You get roughly $100 a month to go and get your nutritional supplements and the vitamins from that store. In terms of pancreatic insufficiency, we have acid reflux. So CF patients, because of the decreased sodium bicarbonate secretion in their CF patients, leads to higher amounts of gastric acid and reflux. So we usually treat these patients with a histamine 2 receptor blocker, antagonist, or a proton pump inhibitor. Examples of these would be famotidine for the H2 blocker and omeprazole for the proton pump inhibitor. These may help reduce gastric acid and improve enzyme efficacy in patients because the concept is that pancreatic enzymes absorb better in a less acidic environment. Roughly 40 to 50% of CF patients are prescribed an acid reflux medication according to the most recent CF annual data report. The first the clinical quandary we have deals with CF-related nutrition, looking at the most recent registry data report when it looks at weight BMI percentile for patients in both the pediatric and adult populations. If we look at from 2019 forward, from the release FDA approval of elexacaftor, tezacaftor, ivacaftor, or ETI, you can see in the pediatric and adult populations there is a significant change in the obesity and overweight categories that has happened, especially on the adult side. ETI approval in the pediatric population is recent for 6 to 11, just 2 years ago, and then last year for the 2 to 5. So you don't see as much significance improvement in the change in the pediatric side, but in the adults, we are seeing that. 65% of CF adults are now at the CF Foundation BMI goal. 13% of patients are considered obese, with the percentage of CF adults overweight and obese more than doubled since 2001. There also are several case reports of patients converting from pancreatic insufficiency to sufficiency, just published in the last couple years, and a decline in enzyme replacement therapy use in patients who are on ivacaftor, and that's a recent publication. There also is a recent study that was published that showed a survey that was done of CF patients and providers showing decreasing acid suppression use and decrease in doses of pancreatic enzyme replacement therapy in patients on highly effective modular therapy. So the question that we have is, what would you do if you were in this situation, if you have patients who are in the obesity category or increasing weight, as well as patients who are maybe converting from insufficient to sufficiency or decreasing their enzyme replacement use? As a center team, what would you do to help address these situations? There really is no specific answer to this question. However, there is an article that was published by Gable and colleagues, which was a group of CF dietitians as well as providers that published this in Pediatric Pulmonology in 2022, that offers some suggestions to answer this clinical quandary of how to address nutritional approaches in the era of highly effective modulators. The main takeaway points from this article is that CF providers need to start conversations with patients about what is actually going on with the modulators and how absorption is changing and how this is affecting their body. Utilizing motivation interviewing techniques to work with patients, providing individualized nutritional and exercise approaches are outlined in this article to have those conversations with those patients. And also consider medication interventions for obesity and overweight if needed. The next area of pancreatic insufficiency that we can talk about is fat-soluble vitamin deficiencies. Due to the decreased pancreatic enzyme secretion, the fat absorption is decreased, and so then that affects the fat-soluble vitamin absorption, and so the levels will be decreased. And the fat-soluble vitamins we're worried about are the fat-soluble vitamins ADEK or ADEK. Also, water-soluble vitamins and minerals can be affected, especially zinc, since it's associated with vitamin A absorption. From the CF Foundation, there are recommendations to monitor the levels at least annually, and supplementation is essential, and roughly 90% of all CF patients are on some sort of vitamin supplementation. The CF-specific vitamins that are available for supplementation on the U.S. market, as well as international markets, we have the MVW Complete Formulation line through MVW Nutritionals, and they have various formulations of drops, chewables, gummies, soft gel minis. There's the vitamin D line of extra vitamin D, D3000, D5000, and then there's the MVW modular formulation drops, soft gel minis, and chewables, which are coming soon, which have been released and are the newest products on the U.S. market. Genedec is an international vitamin that is available through MVW Nutritionals. It can also be ordered through their website that has drops and chewables as well as increased vitamin D amounts. Decas is a line through Callion Pharma, which provides Decus Essentials, and Decus Plus, which provides drops, chewables, and soft gels. All of these can be accessed via the company websites, enzyme program, value-added program websites, as well as the retail pharmacies with a prescription. The clinical quandary that's associated with this area is that with all these patients on CF-specific vitamins, we are seeing studies and case reports of individuals that have increased vitamin levels as well as toxicities in patients taking CFTR modulator therapy. And the most recent studies came out in earlier this year. With all of that, there is concern about exactly what is happening on the CFTR modulator on the vitamin levels. Usually vitamin A is the one that increases the most, and that's where we're seeing the toxicities. And so with that toxicities, the question would be, what do you do to help prevent the toxicities from happening in these patients? So the nutritional quandary number 2, their options are available would be to take your CF-specific vitamin and modify the dosing. However, more of this, we will more into detail in our second webinar on CF nutrition. We go through this area specifically, talking about the different case reports and studies, and get more into the recommendations of what can be done. But the MVW modular formulation vitamin has been specifically designed and formulated for individuals who may have higher vitamin A, D, or E levels, and they're on a CFTR modulator. And the reasoning it is designed has lower amounts of the preformed vitamin A, retinol palmitate, but higher levels of the provitamin A beta carotene. And the design is so that patients who are on a modulator will not be may not have as much risk of toxicity by taking this vitamin instead of just checking levels. And refer to webinar 2 of the series CF Nutrition for more information about this topic. In terms of hepatobiliary disease, almost 4% of the U.S. population is affected with CF liver disease, as associated with the impaired chloride water secretion at the bile duct level, leading to thick secretions in the bile ducts that can lead to portal fibrosis and cirrhosis of the liver. The quandary that's associated with this comes with the new guidelines and the medication that was used by CF patients to help treat CF liver disease. Roughly 12% of all CF patients are on ursodeoxycholic acid, or ursodiol, in the most recent data report for the treatment of abnormal liver function tests or CF-related liver disease. However, studies that were published have shown mixed results in the efficacy of ursodiol. In the most recent guidelines for hepatobiliary disease published by the CF Foundation just last year by Sellers and colleagues, no longer routine recommends the ursodiol for routine use. With all the patients who are on CFTR modulators, one of the most common and serious side effects of a CFTR modulator therapy is elevated liver enzymes, liver damage, and worsening liver function. So the clinical quandary associated with this one is, what do you do when you don't have a medication now that is not recommended by the CF Foundation to treat liver function, or may not do anything? What do we do in those patients who are having issues with CFTR liver issues? So if a patient is on a CFTR modulator and experiencing elevated hepatic function labs, the best things to do would be first consult with your CF clinic providers to determine the best plan of action. Maybe hepatology can get involved, but that is probably the best approach to exactly what you need to do. There are package inserts done for each of the CFTR modulators for recommendations on liver dosing. There is a new publication that just got published a couple weeks ago out of the Netherlands by Vonk and colleagues that recommends a stepwise introduction of ETI in patients with severe liver disease. and they'll refer you to that article for any of how to best approach that. But again, this would be an individualized approach, working with all CF clinic providers to find the best course of action for each patient. The next area where a CF medication therapy exists would be the endocrine system, or with the pancreas and the endocrine portion of the pancreas. And this is where insulin is produced. With patients with cystic fibrosis, with the endocrine portion being damaged in these patients, it can lead to a condition called CF-related diabetes, or CFRD. Roughly 19% of patients have CFRD according to most recent register report, with 30% of those being in the adult population and less than 5% under the age of 18. We don't start screening for this until age 10, so that is why it's more prevalent in the adult population than in the pediatric population, because it's a progressive damage to this pancreas instead of like the exocrine portion, which you see almost immediately. It has been associated with decreased weight gain, decreased lung function, and increased mortality, so that is why it's recommended to treat patients with CF-related diabetes. Also, increased risk of microvascular complications, so affecting the eyes, the nerves, and the kidneys of patients, lead to retinopathy, nephropathies, and neuropathies. Macrovascular complications at this time really have not been seen, but as patients live longer, this may be an issue. From CF nutrition, the recommendations from the guidelines are to have high calorie, high fat, high salt diet for patients unless they are obese. And then the guidelines are released by Odie and colleagues in 2022 actually recommend to have low-fat diet if a patient is obese. If the only treatment that is recommended by the CF Foundation is insulin. Either a basal bolus or insulin pump is the only recommended studied therapy, with roughly over 70% of all CFRD patients treated with insulin. There are other therapies being studied at this time, but this is the only recommended therapy by guidelines. With the clinical quandary of CFRD, we see all these patients now with obesities, be considered obese and overweight. There are case reports of the positive benefits of CFTR modulators on glucose management of our patients with CFRD. If you look at the positive effects from these studies that have come out, the hemoglobin A1Cs are decreasing, which is the measure of control for a patient with diabetes. We're also seeing declines in fasting blood glucoses, and then glucose management be much better followed by a continuous glucose monitor. We're also seeing patients with insulin doses also declining. One of the things, however, we're seeing issues with metabolic syndrome, which may be due to the effects of the modulator on fat mass and also on cholesterol levels. And so that's something that probably needs to be looked at as a team, of how you monitor the patient is best, because of them living longer and the long-term effects, we may be seeing the macrovascular complications, and this is just something to screen the patient to make sure we are avoiding those in the future. So what do we do for these patients in this scenario, given all of these effects on the CFTR modulator on CFRD? So this is where a nutritional approach, following the clinical quandary number 1 recommendations by Gable and colleagues, as an individualized nutrition exercise approach for these patients to focus on healthy diet and exercise. For the glucose management of the CFTRs with CFRD, this is where more research is needed to how best approach CFRD management in this era of highly effective modulators, but we have positive indication that CFRD management may change. And so that's where we're working as with a team with endocrinology to figure out the best approach for this patient individually. The last area where we have medications with the lungs or the pulmonary system. The overall goal of our CF patients are to have healthy, pristine lungs, and that would be the goal of all of us because they would live longer and they have decreased morbidity and mortality. So we have medications now that we have currently that help alleviate the symptoms, but also with the modulators, they are helping our patients living longer and having healthier lung function. When we look at the management of the pulmonary issue, we start with the non-pharmacologic. And so this is where we have various devices for airway clearance that are used. We have chest physiotherapy that can be done by parents and also respiratory therapists for patients, especially if they're young, they're not able to qualify for a vest. And so that's where chest physiotherapy to help with the obstruction and the secretions is available. Vest therapy or the pneumatic vest therapy is the most commonly used system in U.S. patients to help with the obstruction and the secretions. But not one is better than the other. All of them by guidelines are considered equivalent as long as they are done. The second area, the worst medications that we use that are used in conjunction with airway clearance therapies would be bronchodilators. And this would be your inhaled beta agonists such as albuterol, levoalbuterol, and your inhaled anticholinergics such as ipratropium and tiotropium. All of these help with the obstruction and opening up the airways. According to the CF guidelines, none of them are recommended for chronic use in our CF population and to improve lung function. They are more for symptom-based management as pre-treatment for the medications that come after, which can have side effects of bronchoconstriction. After the bronchodilators are done, the next medications are done in the order of therapy would be your mucolytics. And so there are 3 that are used and routinely recommended by guidelines or by approval by the FDA. So we have hypertonic saline, which is done usually after a bronchodilator because the most common side effect of hypertonic saline is bronchoconstriction. Hypertonic saline improves by osmosis. The high concentration of salt pulls water from the lungs to liquefy the mucus and help get it out and induce cough. Dornase alpha can be used after hypertonic saline if they're used in the same treatment or by itself. It's a once daily medication that is FDA approved to help break down the white blood cell DNA in CF mucus and thin it and make it easier to cough up. It's a medication that's been shown to improve lung function and keep people out of the hospital. Inhaled mannitol is a medication FDA approved in adults. The mechanism of action is unknown at this time, but the thought process is very similar to hypertonic saline. It's a high concentration sugar which can get into the airways and pull water from the lungs to help liquefy the mucus. It's not approved at this time in pediatric patients. The next medications that would be used in order of therapy, if you have bacteria such as Pseudomonas in the lungs, this is where an inhaled antimicrobial would be used. And so you have inhaled tobramycin, inhaled as Trianam, which are FDA approved for either as a podhaler for the tobramycin or nebulizer for the tobramycin, nebulizer solution. Inhaled as Trianam, it is used with a separate device through the Altera nebulizer system. Those are both FDA approved. Inhaled colistin is used as an IV formulation that is inhaled in the United States. In other countries in Europe, Canada, and Australia, it is approved in those countries as either a dry powder or a solution that can be given to patients. In the CF guideline, in the CF drug pipeline, inhaled colistin is being studied and to be used as an FDA-approved product for inhalation. So that is something that is coming in the pipeline. Inhaled amikacin is FDA-approved, not for cystic fibrosis and not for Pseudomonas, but it is FDA-approved for adult patients who have Mycobacterium avium complex. But it has been studied in the CF population for the treatment of non-tuberculosis mycobacterium and Pseudomonas. Oral and IV antibiotics are also recommended to be used for patients and have dosing for patients who have various infections. For more, we have the third webinar in the series. We'll go into more detail about the dosing of antibiotics and the various bacteria that we use to treat. This is a most recent data registry of the prevalence of respiratory microorganisms by age cohort in the CF population. And again, we will cover this more in the third webinar of our series. All of these medications have assistance programs that are available to patients with commercial prescription insurance. So the Dornice Alpha program, they do have a copay assistance program that provides $10,000 per year for all patients with a $30 copay. You can enroll them via this website. Also, if you are a CF team, you can go in and you can help the patient and follow them. There is a portal that you can enroll in as a pharmacy or as a care team to follow your patients and follow them in terms of how much monies they have left on the card and what the copays are and where they're filling. The inhaled mannitol has a copay assistance program, as well as some of the inhaled tobramycins. All have programs. Inhaled astrienam and inhaled amikacin have programs. Those are a little bit different. They actually enroll the program and they manage the patient and will follow them and will provide the copay assistance to the specific specialty pharmacies where they can get them from. When we look at inflammation, there are anti-inflammatory medications that are available for the treatment in cystic fibrosis that guidelines recommend or do not recommend. So ibuprofen, at this time, less than 2% of all CF patients, usually they're adults, are using ibuprofen for the treatment of inflammation in the cystic fibrosis population. This was studied a long time ago and showed that it helped decrease the rate of lung function decline in the pediatric population, but not in the adults. And so it is recommended, but hardly ever used due to formulations as well as side effects that can happen. Azithromycin is recommended by the CF guidelines for the treatment of inflammation in patients with Pseudomonas, as well as non-Pseudomonas. It can be a provider can look at also using that in patients that may benefit. It's dosed 3 times a week in most populations when it was studied, and basically in conjunction with other anti-pseudomonal agents. Leukotriene receptor inhibitors and inhaled corticosteroids are also anti-inflammatory medications. Your leukotriene receptor inhibitors are an example that would be montelukast. It has a recommendation of we don't know the benefit of in a CF population. It needs more study at this time. Roughly 15% of CF patients are on a leukotriene receptor inhibitor. Most of the time they use it for other inflammatory issues such as allergic rhinitis or asthma. Inhaled corticosteroids, They're actually recommended against in the CF guidelines for routine chronic use, unless you have CF-related asthma or a condition called allergic bronchopulmonary aspergillosis, or ABPA, where they are recommended in those patients. When we look at the clinical quandary related to pulmonary medications, this looks at the decline in the prescription, number of prescriptions that are being filled in these patients since 2019. And you can see all of the available inhaled medications that are recommended by the CF Foundation are seeing a significant decline in their utilization since the advent of highly effective modular therapy. So what's happening is you have studies that have actually supported this as well. So there was a survey that was done by the CF Foundation in 2023 that looked at individuals on CFTR modulators and shows that they are decreasing one or more therapies. They showed that parents of children, roughly a third of parents of children and over half of adults with CF are doing fewer airway clearance treatments. And then over 10% of adults have stopped their airway clearance techniques completely. Roughly half of all CF providers who were surveyed have decreased their plan for airway clearance techniques for patients on highly effective modular therapy due to the fact that they are improved and to help with adherence, because they may not need it at this time, but that was just what they found in this survey. There's a study that has been published by Mayor Hamblett and colleagues, was done by the CF Foundation, called the Simplify trial. And this was a randomized controlled trial in patients over the age of 12 that were on a highly effective modulator. It showed that was done to see if they could discontinue either hypertonic saline or Dornase alpha to see if there was any benefit by decreasing therapies and if there was any effect on lung function. And the results, they found there was no difference in the change in FEV1 in discontinuing or continuing in the groups for both patients. In hypertonic saline, there was no difference in lung function if they continued or discontinued the hypertonic saline, as well as in Dornase alpha. There was no difference in patients who continued or stopped the therapy. A follow-up study to that, called the MCC Simplify, looking at mucosal clearance, they looked at in those patients, they looked at the mucosal clearance issues and actually found that with hypertonic saline, if those patients stopped, there really was no effect on the mucosal clearance if stopped. However, in the Dornase alpha, the mucosal clearance improved if they stopped Dornase alpha. This was done in a small subset of the initial Simplify trial, but may show that patients may actually benefit from stopping Dornase alpha on a highly effective modulator. That's one of the theories. We don't really know. More study has to be done at this time. But there were no major adverse effects occurred in those patients. However, those in lower lung function had more adverse effects of cough and nasal congestion when therapy is discontinued. So the overall conclusion from this study, that discontinuation of inhaled therapies is not associated with short-term lung function changes in patients prescribed highly effective modular therapy, especially those with higher lung function. So what is a team to do with what's happening in the real world of CF? So to address this quandary, more studies are needed to show the long-term effects on lung function, overall health, with decreasing airway clearance techniques in patients on highly effective modular therapy on lung function. These studies are being done at this time, so we'll have more information soon from the CF Foundation. Patients are doing it on their own, regardless of study results. Care teams and specialty pharmacy teams need to be aware that the patients have stopped therapy, and it allows for an individualized approach to ask questions why they aren't filling their medications. And this leads to a better conversation, so you know exactly what's going on. It's not currently recommended, but things may change as results of those studies come out from the foundation. That have come out. These are the modulators that we have currently on the U.S. market. Ivacaftor was approved in 2012 and is now approved down to age 1 month of age. Age 1 month, sorry. And then Lumacaftor Ivacaftor is FDA approved down to 1 year of age. Tezacaftor Ivacaftor is FDA approved down to 6 years of age, and Alexacaftor, Tezacaftor, Ivacaftor approved down to 2 years of age. All of these affect the CFTR and either correct correct the channel and then potentiate it, or they are potentiators depending on the class mutation, but overall affecting the entire CF disease process. There is a new one that is being studied called the once daily Vanza triple. So it's Vanzacaftor, Tezacaftor, Ivacaftor, and 3 studies have been randomized controlled trials have been completed comparing it to ETI. These results were just released by the manufacturer, Skyline 101, 102 and 103 in patients over the age of 12. The primary endpoint, it was a non-inferiority study, showed there was no change in FEV1 when comparative change between Vanza triple and ETI, so they are equivalent. They both improved lung function, but at an equivalent rate. So there is no difference between them in terms of change in FEV1. The secondary endpoint, looking at change in sweat chloride, they did show that the Vanza triple was superior to Alexacaftor, Tezacaftor, Ivacaftor at in improving sweat chloride change, as well as the percentage of patients that got had a decrease less than 60, which is a number of 60, which would be the number that would be considered a patient would have CF, less than 30 if they're considered a carrier, with Vanza triple versus ETI. Both medications have side effects, but it did show that the Vanza triple was well tolerated when compared to ETI. In the Ridgeline 105 trial in patients 6 to 11, the primary endpoint was safety, and it was shown to be well tolerated in this patient population. And the secondary endpoint showed a change in sweat chloride, that the Vanza triple was superior to ETI by decreasing sweat chloride by an average of 8.6 millimoles per liter, and 95% of the patients on Vanza triple had sweat chlorides less than 60, and the majority of the patients had less than 30. So it does show to have effect on the CFTR channel and in turning it on and allowing for chloride to move. From the manufacturer, we know that is being submitted an expedited approval to the FDA and hopefully to be approved by mid-2024. The copay assistance program that's available for CFTR modulators through Vertex is called the Vertex Guidance and Patient Support. It's available to all patients with commercial prescription insurance that covers the CFTR modulators. It does provide copay assistance and coordinates with specialty pharmacies so your patients can get their medications. There is a recent change to the Vertex GPS Assistance Program as of January 1st, 2023. It did, if you want to go to that, you can actually refer it on their website. There are significant issues facing CF patients right now with this change. There's an article that was published by a bunch of CF providers in early 2023 that kind of outline some of the effects that this may have on the patients. And we have seen in 2023 that their patients ran into issues of running out of copay assistance money and needed to find alternatives in order to access the medication. You can refer them to CF Foundation Compass as well as to Vertex GPS for further guidance. The Healthwell Foundation CF Treatment Fund does cover the modulators, and it is currently available for patients. It was defunded in 2023, mid-2023, but is back up and running, and so patients can use that for assistance. The clinical quandary associated with CFTR modulators looks at that we have the positive effects, but also some side effects that are happening. So the median age of survival for U.S. patients has increased from roughly 43 in 2016 up to 56 in 2022. And that large jump can be attributed to the modulators coming out in 2019 for our CF patients. BMI and lung function numbers are increased significantly, especially since 2019, and the percentage of adult patients with normal lung function is now over 90%. We now have more patients over the age of 18 than less, as a percentage, than less than 18. So the patients are living longer and having a better quality of life. However, some mental health issues have been reported since ETI was released. And there's several case reports have been published describing changes in depression scores and suicide ideation after ETI was approved in both pediatric and adult patients. So what do we do in this case? Well, the CF Foundation, a group of CF providers, and Vertex actually published a study just recently, as of a couple of weeks ago, by Ramsey and colleagues that looked at multiple clinical trials of ETI. Some of them were placebo-controlled. They looked at registry reports from the United States and Germany and post-marketing adverse event surveillance from 62,000 CF patients from 2019 to 2022, as well as review of the published literature, trying to determine, is there any increased incidence of depression in the patients on ETI. And what they found was that there is no difference in depression and depression-related symptoms in patients with cystic fibrosis on ETI versus the general population from the clinical trials, the post-marketing data, registries, and published literature. So their conclusion is there's no causal relationship between ETI depression and depression-related symptoms. However, work with your team, figure out exactly what may be happening, because each patient may be individual, an individualized approach in order to determine the best course of action for your patients. The last section I'm going to do is going to shout out for the role of pharmacy in CF. Internationally, there are guidelines in the UK and Australia that recommend pharmacy as part of the care team. In the United States, we are considered a recommended provider as part of the CF team. One thing that has happened, these are some articles that have happened just in the last year that highlight what's happening in CF with pharmacy. In 2022, in the most recent registry report, 52% of CF patients were seen by a clinic-based CF pharmacist at least once. A new article by Gruby and colleagues was a survey that was done of care centers that found that 65% of care centers now have a dedicated CF pharmacy presence. This survey was a 10-year survey that compared 2013 to 2023 and showing the change in pharmacy practice areas. It shows that from 2013 to 2023, it's a shift from inpatient to outpatient care, where roughly 60% of all pharmacists were in the inpatient area in 2013. Now 68% of pharmacists are in the outpatient arena in 2023. Care process models for pharmacy teams have been developed, and roles and responsibilities for clinic-based pharmacists and dedicated pharmacy technicians have been outlined in the literature. For the most recent CF data report that was released, the first time ever, pharmacists are listed on the graph. They had respiratory therapists, dietitians, social worker on there. Now pharmacy is on there for the first time and shows the incremental increase of pharmacists seeing the patients, and that shows an increase in the number of pharmacists that are being utilized in the CF clinics. The most recent hepatobiliary guidelines that were published by the CF Foundation recommends that a pharmacist see a patient every 6 months. And this is the first time any guidelines have actually outlined that a pharmacist needs to be involved in the care team. So this is also a great example of what we can do to help our care teams by evaluating high-risk medications, polypharmacy, and recommend therapy modifications based on patients' liver function. This is a pharmacy care process model that was published in an article by Grant and colleagues in 2022 that highlights what a pharmacist can do as well as a technician in a clinic and for clinic flow for a patient and where the medications can go and the different roles and responsibilities of those pharmacists and technicians. This is a table that outlines the roles and responsibilities of pharmacists and technicians both in the clinic and in specialty pharmacies and what they can do for patients to help them to improve medication adherence, but also where the medications need to go and help the team in that process. Another care process model that was just published by Zobel and colleagues in 2023 outlines a low-hanging fruit that was not included in the original roles and responsibilities, and that would be immunizations. Pharmacist immunizations as well as technicians administering immunizations has almost every state in the United States as well as Puerto Rico allow for pharmacists to administer immunizations for patients under a collaborative practice. In this clinic, immunizations was something that was an issue as many patients were not following the CF recommended guidelines in order to receive immunizations such as pneumococcal polysaccharide valent 23. And so a study was done, develop a care process model. A before and after study was done to show improvement of what can be done and immunizing patients in a CF clinic to serve as, instead of the primary care provider doing this, allowing for the clinic to be administering the immunizations to the patients because they see them every 3 months. The results of this study showed that this center was able to give almost 800 immunizations in a year and a half, especially COVID-19, pneumococcal polysaccharide 23 valent, and HPV, being the most ones that were low incidence of patients receiving them. And so those were the three that were most commonly given for the patients to get them updated and following CF guidelines. And this also attributed to a roughly 0.1 to 0.2 FTE, a full-time equivalent for patients, and so can be used for centers who are looking for funding for a pharmacist. This is something that can be done to help both patient care and also improve the care in the clinic. Other results have showed that we were able to, by doing this, we're able to immunize in the pediatric the younger kids under age 2, getting them their routine recommended vaccines for childhood immunizations, as well as in the teenage population, where Utah was where this was done, had one of the lowest HPV rates in the country. We're able to improve our human papillomavirus vaccination for those patients in that population. As well as COVID-19, we're able to compare it to the US and the Utah percentages that we were able to improve those by providing education and also providing immunization in a clinic setting where the patients felt more comfortable. The last publication that was published in 2013 looking at pharmacy was a consideration for effective pharmacy provider handoff. And a group out of North Carolina and Utah published this from their interactions that they had of patients who transferred from one center to the other adult from peds to adult, or from center to center across the country, and what they were able to develop and some of the things that are very helpful. When you look at and passing things off from individuals, medication access and list of medications are probably some of the most important. So when the patient gets to the other center, the new center has that information. They can go off and running, and the patients felt more comfortable when they knew that their pharmacist had that communication. The conclusions of this webinar, we can see that CF is a very complex disorder. Treatments exist to alleviate symptoms and modify the disease process. The complexity of the CF of chronic medications, now with the almost release of the once daily Vanza triple, we use to treat, but they alleviate the symptoms and they're dramatically increased. And we're seeing them change in age and come out with new ones almost every year. We're seeing new ones come out. So care teams as well as pharmacists can play a key role in improving the care of patients with CF. And thank you for all the work that you do in helping our patients to make CF stand for Cure Found. This is my contact information, as well as my colleague, Dr. Kevin Epps, his contact information. If you have any questions, you can refer to us, email us, and hopefully you enjoy this presentation. Thank you.